Our immune system has billions of T cells. We could actually engage more or less all of them to be equipped with the BiTE modality. So here you see a BiTE-equipped T cell attacking a cancer cell. Through the presence of the BiTE technology, the T cell is capable of recognizing the tumor cell as an enemy and then destroying the cancer cell, attacking the next cancer cell, and so on and so forth.
Key eligibility requirement for these patients is that they had to have progressive multiple myeloma per IMWG, they had to have good performance status, they had to have measurable disease, and been exposed to at least 3 or more prior therapies, such as a PI, an IMiD, and anti-CD38. So if we actually looked at who we enrolled on the entire study, we had a total of 97 patients on the combined phase 1b, phase 2 portion of the study. Their median age was 61, and a little bit more than half were male. These patients were actually very heavily pretreated, as their median prior lines of therapy was 6, and it ranged anywhere from 3 to 18. These patients also were pretty heavily exposed to other lines of therapy, as their triple class refractory was 88%, penta-refractory was 42%, and one of the things the study did not require you was to be refractory to your last line of therapy. However, 99% of these patients were indeed refractory to their last line. So the treatment is a one-time infusion that's given after 3 days of lymphodepletion. So patients usually come in, undergo apheresis, and then they're offered bridging chemotherapy as needed. Then all the patients undergo lymphodepleting chemotherapy with fludarabine and Cytoxan from day -5 to day -3, and then they actually get infused with Ciltacabtagene on day 1. And this was given as an inpatient administration. The patients, once they're administered with Ciltacabtagene, have to stay in the hospital anywhere from 10 to 14 days to monitor for any CRS toxicities. The response rate on the study was quite astonishing. It's actually 97% overall response rate, with 67% of these patients going into complete remission, stringent complete remission, and then 93% of these patients were in very good partial remission or better. And if you actually look at the time of data cutoff, which was 12.4 months, we see that 70 patients are still having ongoing responses. And the median time to response for these patients was 1 month. And interestingly, if you actually look at minimal residual disease, which was 93%, was MRD negative at 10 to the -5 in the evaluable patients that we had. Another interesting finding is we know from the Mammoth study that patients with relapsed and refractory myeloma have a median overall survival of less than 6 months if they're penta-refractory. So to see that kind of patient population on this study, we actually did not reach a median PFS. So the 12-month PFS is 76%, and what it shows is that the median PFS is at least a year, because we had a median follow-up of 12.4 months, but we know it's going to be longer since we haven't reached the overall median PFS. We also did not reach a median overall survival, and the 12-month overall survival rate is 89%. We actually did break down the PFS a little further to look at if it mattered based on their response, and we saw that the 12-month PFS for patients in stringent CR was 85%, and in VGPR was 68%. Again, we did not reach a median PFS even for the response as well. We saw that in the entire study, 92 patients ended up having CRS, with mostly 95% of these patients having mostly grade 1 and 2 CRS. One interesting factor to highlight is the time of median onset of CRS, which is 7 days, which is a little later than usual other myeloma CAR Ts or the lymphoma CAR Ts out there right now. I think in this relapsed refractory population, we actually do need a lot of trials, because our myeloma, as we know, myeloma is not a curable disease. So I feel like with the bispecifics, with the ADCs, and now the CAR T-cell therapies, there's going to be a role for every one of these products, but just in a different way. So different patients are eligible for CAR T versus bispecific. So if you had a young patient who's, not progressing rapidly and has good performance status, they'd be a great candidate for CAR T. And additionally, like I mentioned, in our CARTITUDE 2 and 4 programs, we're actually using this more upfront in earlier line settings. So we're hoping that maybe giving it to a patient who's not super relapsed and refractory, maybe we'll see longer and deeper durable remissions in these patients.